Professor Lubna, and we will start Bayer Symposium right now. Good evening, my dear colleagues. Now we will start Bayer Symposium. Unfortunately, Professor Ghassan Abu Alfa couldn't make it today, and I was obliged to give the talk of Bayer Symposium instead of him. These are my disclosures. Position of Nexavar and Stivarga in the HCC evolving treatment landscape. Switching to systemic therapy is the right patient at the right time. HCC accounts for about 90% of all primary liver cancer and is the third leading cause of cancer-related deaths worldwide. Treatment of patients with HCC in the advanced stage remains a great challenge with few drugs approved. Recently, there have been multiple new agents approved and positive results for emerging agents in clinical trials. As we all know, HCC is two diseases, underlying liver disease and the tumor. And the risk factors for HCC are hepatitis B virus, hepatitis C virus, alcohol-related cirrhosis, and metabolic disorders. Classifying HCC, two diseases, liver disease and cancer. Liver disease is classified by Child-Pugh score, incorporates laboratory, radiological, and subjective assessment. Cancer is classified by stage, potentially resectable or transplantable, operable by performance status or comorbidity. Unresectable disease, inoperable by performance status or comorbidity with local disease only, and metastatic disease. Child-Pugh liver score is very important. 5 factors rated 1 to 3, total bilirubin, albumin, INR, presence of ascites, presence of encephalopathy. Child-Pugh score A, B, C. A is liver can tolerate treatment and patients tend to be treated aggressively. Class B, the liver is compromised and may not be able to tolerate treatment. And class C, the liver is too damaged to be able to tolerate treatment. As we see here, the BCLC staging system, early BCLC-A, treatment recommendation, resection, transplantation, ablation, SPLT, and on recurrence will be treated as intermediate BCLC-B by TACE or transarterial radioembolization. And if patients are unsuitable for TACE or transarterial radioembolization, we will move to advanced BCLC stage C with first-line systemic therapy and upon progression to second-line or third-line. And terminal personnel criteria D, the treatment or recommendation is best supportive care. As we see here, the first approved systemic therapy for HCC was sorafenib, based on the SHARP trial by Professor Louvet in 2007, and the approval was in 2008. And then for 10 years, we have negative phase 3 trials, and the only dogma for treatment for advanced HCC was sorafenib, until the non-inferiority reflect trial and the approval of lenvatinib in first line, and recently in first line we have atezolizumab approved in May 2020, and in second line we have regorafenib, cabozantinib, ramucirumab, and we have accelerated approval for nivo and pembro and nivo plus or minus ipilimumab. So eligibility for TACE should consider tumor burden, underlying liver disease, and performance status. And according to ESMO 2018, the eligibility criteria was single tumor any size less than 3 nodules, less than 3 centimeter, preserved liver function, ACOC performance 0. Patients with contraindication against resection and thermal ablation bridging to transplantation. PCLC-B, multinodular, preserved liver function, ACOC performance 0. According to EASL 2018 guidelines, optimal candidates for TACE are uni or pussy-nodular disease, no vascular invasion or metastasis, asymptomatic Child-Pugh stage less or equal to B7. TACE is not recommended for patients with declining ACOC performance more than 2, severe hepatic decompensation, Child-Pugh decompensated cirrhosis, inadequate hepatic function, tumor burden more than 50% of total liver volume, macrovascular invasion, segmental portal vein tumor invasion, biliary enteric anastomosis or biliary stent. Determining when to switch from TACE to systemic therapy may be the key to patient outcomes. And this is very important. We have, according to ESMO, if a substantial necrosis is not achieved after second session or when a subsequent session fails to induce remission at sites that have initially responded to TACE, in patients with untreatable progression, including major progression, extensive liver involvement, extrahepatic metastasis, or vascular invasion. So here, let's meet a real-life example. Let's meet Hans, who is 62 years old. Hans is a carpenter who enjoys working with his dog. Medical history diagnosed with unresectable HCC, HCV etiology, received 2 previous rounds of TACE. Current symptoms: intermittent mild abdominal pain, comorbid hypertension, unresectable HCC status, portal vein invasion, BCLC stage B, Child-Pugh score A, ACOC performance 0. Hans treatment timeline: he underwent first TACE from November to December, and then second TACE from December to February, with nodules remained unchanged, stable in segment 5 and 6. Then in March 2019, there was a progression of the nodules and 1 new nodule in segment 4, and he started Nexavar with a standard dose 400 milligram twice daily. Initial evaluation in the first week, there was increased fatigue and increased sleep and hygiene exercise. First month's follow-up, partial response, and the segment 4 nodule disappeared, but there was increase in fatigue and weight loss. And we did dose modification and decreased the dose to 400 milligram once daily. Then second month's follow-up, stable disease and fatigue resolved, and the patient was still on the 400 milligram dose. And after 6 months follow-up, we maintained the stability of the disease with the 400 milligram once daily dose. So a very important issue was addressed in the Optimus study design, in which we need to start systemic therapy as soon as TACE becomes refractory or there is failure to TACE. Because the more TACE, the more the liver is decompensated and will be unable to tolerate systemic therapy. So according to Optimus trial, cohort 1 was patients with early start of Nexavar at the time of TACE ineligibility, and cohort 2, patient without early start of Nexavar at the time of TACE ineligibility. And the result for cohort 1 was 16.2 months overall survival, and for cohort 2, it was 12.1 months, which denotes we have to start systemic therapy as early as possible in PCLC-B patients. And we have to identify who are the patients who become refractory to TACE as early as possible before our liver becomes decompensated. Nexavar is a multi-kinase inhibitor with a dual mechanism of action to inhibit tumor growth. Nexavar or sorafenib demonstrates both anti-proliferative and anti-angiogenic properties by inhibiting the activity of multiple kinases present in tumor cells and vasculature. Nexavar daily dose is 400 milligram twice daily and should be swallowed with a glass of water, either with food or with a low-fat or moderate fat meal. Taking Nexavar with a high-fat meal reduces absorption. And if the patient tends to have a high-fat meal, Nexavar should be taken at least 1 hour before or 2 hours after the meal. And when we want to do dose reduction according to adverse events, we have to reduce it 2 tablets once daily. So the first reduction is from 800 is to 400 milligram once daily. And no dose adjustment for older age or patients with Child-Pugh A or B. As based on the SHARP trial 2007, Nexavar was the only systemic therapy approved for over 10 years. And the SHARP trial, the median overall survival was 10.7, and median overall survival for placebo was 7.9. And the following Asia-Pacific trial, median overall survival was 6.5 months versus 4.2 for placebo. And remember, the median overall survival in the Asia-Pacific trial was less than the SHARP trial, because in the Asia-Pacific trial, Asian patients, more patients with hepatitis B were included. And as we all know, the best response with Nexavar or sorafenib is in hepatitis C patients. And the more trials we do with sorafenib, the more we are getting experience with the adverse effects of sorafenib, and the more results we get with sorafenib. And as we see here from several trials, recently, the Checkmate 459, the overall survival with sorafenib was 14.7 versus 16.4 for Nivo. And in the recent IMbrave 150 trial, the sorafenib arm, the median overall survival was 13.2 months, which means that the more we are getting experience with the toxicity profile of sorafenib, we will get better results. And Professor Ghassan Abu Alfa has presented this before and showed that in the sorafenib, stable disease and tumor necrosis can be translated into progression-free survival benefit and overall survival benefit. The adverse events in the SHARP trial was what we know for TKIs, diarrhea, hand and foot syndrome, anorexia, alopecia. And in Asia-Pacific trials, more than 10% of the patients experienced also diarrhea and hand and foot syndrome and hypertension. The Gideon study, incidence of adverse events was not significantly affected by Nexavar dose. And here is a comparison for 800 milligram versus 400 milligram. And as we see here, as regarding median time to tumor progression or adverse events or incidence of serious adverse events, there was no difference, and maybe sometime slightly increased in the 400 milligram per day versus 800 milligram. So now, as we all know, the landscape has changed in May 2020 by the approval and the addition of atezolizumab, according to the IMbrave 150 trial. And we are honored to have Professor Richard Finn, who is the principal investigator of this trial, after my talk. And he will talk in details about this trial. The key inclusion criteria for IMbrave 150, the inclusion criteria was local advanced or metastatic unresectable HCC, no prior systemic therapy, more or one measurable untreated lesion, ACOC performance 0 to 1, child view class A, adequate hematological and organ function. Exclusion criteria: history of leptomeningeal disease, autoimmune disease, history of bleeding, moderate or severe ascites, co-infection with hepatitis B or HCV infection, known fibromyalgia sarcomatoid or cholangiocarcinoma, untreated or completely treated esophageal or gastric varices, a prior varicose bleeding, inadequate arterial hypertension, prior history of hypertensive crisis or hypertensive encephalopathy, evidence of bleeding diastasis. The patient population in IMbrave 150 was highly selective. There were key exclusion criteria in the IMbrave 150 trial, mostly centered around the risk of bleeding with BIVA that have not been used in previous HCC trials. Selected exclusion criteria: varices at high risk of bleeding, a prior varicose bleeding, history of hypertensive crisis, inadequate control hypertension, any evidence of bleeding diastasis. A patient population in IMbrave 150 was not representative of the patients with HCC commonly seen in clinical practice, and more comorbidities must be taken into account before adopting the combination therapy. The summary of the adverse events, what was observed, that hypertension was increased with the atezolizumab arm versus sorafenib. So, as we all know, atezolizumab became one of the standard of cares as first-line therapies, and we have the other options, sorafenib and lenvatinib, and we have a problem how to choose between atezolizumab, sorafenib, and lenvatinib, and we prefer atezolizumab for child BUA liver function, no untreated varices on screening for varices to avoid bleeding risk. Prefer sorafenib or lenvatinib for child BC liver function, recurrent post-transplant, not a candidate for immunotherapy, and non-IV administration. And we have to select case-by-case decision, history of autoimmune disorder and varying liver function over time. And because the recent approval of atezolizumab in first-line setting, we have a problem. The problem is that most second-line options are after progression of sorafenib. So what will we do after progression on atezolizumab? This is a problem. Some experts say we can move sorafenib and lenvatinib to second line and move the second line option to third line. But till now, we have three options: sorafenib, lenvatinib, and atezolizumab as a new standard care. And remember, atezolizumab is the first IO combination to have an overall survival benefit in first line. All other trials failed to show overall superiority. And we have also in first line now ongoing promising trials. We have the Himalaya, which is the biggest trial in HCC, 1,200, comparing durvalumab, tremelimumab versus sorafenib. And we have the LEAP 002 study, pembro plus lenvatinib, and we have the Cosmic 312, cabozantinib plus atezo, and we are waiting for the results of this trial. So these are the NCCN guidelines, and we have them first line sorafenib, lenvatinib, atezo, and based on the positive result of the Checkmate 459 as regarding overall survival, although it is a negative trial, the highest overall survival achieved with a single arm IO, it was 16.4 months for Nivo. So if a patient cannot tolerate combo IO or a TKI, Nivo is an option. So optimizing the patient experience with Nexavar and Stivarga sequencing. Consideration for second line treatment selection, first line therapy, child abuse status, toxicity profile, and contraindication and performance status. And second line target therapy, we have 3 trials, positive phase 3 trials, regorafenib, ramucirumab, cabozantinib, based on the Resource, REACH2, and Celestial trial. And they are different in the trials because Resource patients must be tolerated sorafenib in first line, and REACH2 is for patients with alpha fetoprotein more than 400 nanogram per milliliter, and cabozantinib is explored in second line and third line, and it is unique for its MET target inhibition. And as we all know, MET is one of the mechanisms of resistance for sorafenib. And the best median overall survival was 10.6 for regorafenib, then 8.5 and 10.2 for cabozantinib. Immunotherapy approval based on accelerated phase 2 trials, Nivo and Nivo plus ipilimumab based on the Checkmate 040 trial, and pembro based on Keynote 240 and 224. So deciding second line, deciding on a checkpoint, patient did not achieve a significant benefit with a TKI, and deciding on TKI for patient who rated the TKI well. Regorafenib in particular has been studied with robust data according to the Resource trial. Cabozantinib has different mechanism of action, and ramucirumab for patients with alpha fetoprotein more than 400. Let's meet Susan, 70-year-old business owner, diagnosed with unresectable HCC, alcohol etiology, treated with Nexavar, initially rated 100 milligrams, then 400 milligram per day. Current symptoms, mild fatigue.
هو استنى هو كلمه.
Please.
انت فاهم ابوك بيستنى؟ تبص تلاقي الواحد ممكن في عز بتاعي يتصل بيه عشان يقول له بقين كده بس عشان يرتاح نفسيا.
The sound, please. Current symptoms, mild fatigue, unresectable HCC, BCLC-B, alpha fetoprotein 400 nanogram, child abuse A, AST and ALT is 34 and 32, ACOC, Bromus 1, bilirubin 1. Patients received Nexavar from March 2018, and patients reduced dose to 400 milligram in June 2018 until disease progression, and we had to start Stivarga, regorafenib, 130 milligram per day, 3 weeks on, 1 week off, once daily, and the patient achieved a partial response and with some toxicity, so we had to reduce the Stivarga dose to 120 milligram, and then stable disease, and then we re-escalated the dose to 160 milligram again, and patients remained on stable disease till June 2019. So Stivarga inhibits multiple kinases involved in tumor growth and progression, acts on tumor immunity and metastasis and oncogenesis and tumor angiogenesis. Stivarga is indicated in adult patients who have been treated with Nexavar and must tolerate Nexavar and have received at least 400 milligram in the last 20 days of the last cycle. And it's noted to take Stivarga at the same time each day. Stivarga should be swallowed with a glass of water after a light meal that contains less than 30% fat. And the ritual dose is 160 milligram once daily. And if you want to reduce the dose, we reduce it by 40 milligram to 120 milligram. And the least or lowest recommended daily dose is 80 milligram. And we can increase the dose again upon resolving of the toxicity from 80 milligram to 120 to 160 milligram. As we said before, the patient must be tolerating sorafenib in first line for at least with the lowest dose 400 milligram in the last 20 days, and child abuse must be preserved with a performance status one at the time of Nexavar failure. As we see here, the overall survival was 10.6 versus 7.8 for placebo, which is highly significant. And what is very important is that the sequencing of Nexavar and Stivarga achieved a median overall survival 26 months versus Nexavar placebo 19.2, which is the highest sequence of a TKI in HCC. For the first time, we can achieve over 2 years in HCC through adding Nexavar to Stivarga in first line and second line. These are Stivarga improved time to tumor progression, irrespective of time to tumor progression on prior Nexavar treatment. And this analysis was done by Professor Richard Finn and showed that Stivarga showed a consistent time to tumor progression benefit compared with placebo, irrespective of time to tumor progression on prior Nexavar, with hazard ratio ranging from 0.26 to 0.66. The adverse events, the patient characteristics, and all are in favor of Stivarga versus placebo. Again, the treatment measured adverse events were with what we know with TKIs, hand-and-foot syndrome, hypertension, and Stivarga dose modification. As we said before, when we try to dose modify Stivarga, we decrease by 1 tablet from 160 to 120 to the lowest dose modification of 80 milligram. And upon the toxicity resolved, we can increase again to 120 and 160. Most adverse events, as we all know, hand and foot syndrome, diarrhea, fatigue. And what we have seen is if the patients have experienced hand and foot syndrome early, the more response we will achieve. So the earlier the toxicity or hand and foot syndrome with Stivarga, the better the response as we see. The exploratory analysis development of hand and foot syndrome with Stivarga has been associated with a prolonged overall survival. Here, as I show you, is the treatment algorithm for advanced HCC. In first line, we have sorafenib, we have lenvatinib, and we have recently atezolizumab as first line. In second line, we have regorafenib, cabozantinib, ramucirumab, and nivo and pembro, and nivo plus epi. What is very interesting here that the approval of sorafenib and regorafenib, cabozantinib, and ramucirumab was based on phase 3 trials with a superiority design. Also, the Embrave 150 can be added to this phase 3 trials. But lenvatinib was added upon a non-inferiority trial, which was a reflect trial, and it failed to show a superiority, but it met the endpoint of non-inferiority. And nivo and pembro and nivo plus epi had accelerated approval based on phase 2 trials. And this was presented by Professor Ghassan Abu Alfa last ESMO GI 2020, where we have maybe the new options. We have a standard new option atezo plus Piva in first line, and we are waiting for the results of lenvatinib plus pembro or Durvalumab plus Remi and other cosmic trial. So still, for right now, we can have sorafenib in first line, then regorafenib in second line, and preserve cabozantinib for third line. And we can have also in first line lenvatinib and then cabozantinib. And we have second line options also ramucirumab, pembro, nivo, and nivo plus epi. So the sequence of Stivarga and Nexavar and Stivarga, sorafenib, regorafenib, is one of the best sequencing with 26 months overall survival in patients with preserved liver function in metastatic or unresectable HCC. So factors influencing treatment decision: frontline best candidate for sorafenib or lenvatinib, example extrahepatic disease, HCP etiology, alpha-fetoprotein level, importance of overall response, comparison of adverse events, hand and foot syndrome, hypertension, catastrophic bleeding, second line patients who failed either sorafenib or lenvatinib, patients with alpha-fetoprotein over 400, ramucirumab for frail patients. For patients with preserved liver function or less frail, we have the option of regorafenib and cabozantinib, and immunotherapy also is a reasonable option. These are the guidelines for second line. We have regorafenib, cabozantinib, ramucirumab, lenvatinib, nivo plus epi, sorafenib, and pembro. And as we said before, if sorafenib was not used in first line, we have sorafenib and lenvatinib in second line. Thank you for your attention. And I would like to thank Bayer again for inviting me for this symposium. Unfortunately, Professor Ghassan Abu Alfa couldn't make it today, and